Can you see me now?
No.
Really?
We could see you when you joined in, and you were talking about the kids, and then you went off screen.
Huh, okay. Well, my face is popping up on my video,
Yeah.
but I'm not sure why it's not going through WebEx. Low bandwidth.
Interesting.
Don't we all have low bandwidth? Isn't that why we're on this call today?
That could be your opener.
So I'm sorry if my face is not showing up. I've got AT&T fiber, which is supposed to be resuming fast.
Is it possible you have another screen open with video? Because sometimes that can show like you see the video in two places, but it only transmits.
Oh, I can check. That's good. Thank you for your tech support.
I only know because it's happened to me before.
Let's see. Did we want to get started right at 12, or do we want to wait a minute or two, Manasi?
No, let's get started at 12 sharp.
All right.
Melissa and Jade are not going to be able to join today, so we are not waiting on them.
All right. And you still can't see me?
Nope, low bandwidth.
All right. Thank you, Christy. Christy says I can see you. I'm not sure she's talking to me. Thanks, Christy.
Oh, wow. So attendees can, I guess. Yeah. I mean, that's great if they can see you.
You just have to imagine. Our speakers just have to imagine my face, I guess. I'm not the focus today, so.
Okay.
I'm just the disembodied voice that's saying next slide.
Okay, we are about a minute away and we'll get started shortly. Thank you, everyone.
Right just now. Yes.
All right, so we have the recording going. So I think we can go ahead and get started here. So let me just say welcome everyone to the webinar today. We always appreciate this gathering of minds interested in well-being, and today, well-being and turnover. If we can go to the next slide. We will have the recording of this available on the National Action Alliance website, and it can be emailed to you. You can use the chat function throughout the session today to communicate with us if you have any questions or comments. Also, closed captioning is available on the lower part of your WebEx screen. We would like to thank you, those of you who have conveyed their commitment to the 5 aims of the National Action Alliance. We encourage all interested healthcare systems to visit the National Action Alliance website to understand the commitments process, which involves having an executive leader in safety pledge on behalf of the organization. Organizations can formalize their commitment by submitting it via email to nationalactionalliance@hhs.gov. So just to give you a quick introduction, this is a 3-part webinar series. We did it October, November, and December, and we're focusing on how to influence leadership behaviors to promote patient safety, how to address workforce burnout as a driver of patient safety, and how to work on this turnover crisis, which we'll be talking about today. The agenda, just to give you a quick overview, is we will do a recap of the first 2 sessions from October and November. Then we're going to switch and talk and meet our speakers and hear their presentations. And we'll have a Q&A and a conversation at the end, followed by a call to action. So we can now recap our previous sessions. What I'd like to share with you from session 1, which was a really fascinating chat with Dr. Alan Frankel. He gave the first talk there, talking about the links between emotional exhaustion in healthcare workers and leader rounding. He talked about traditional safety rounding versus kind of positive rounding, and how that was linked back to the psychological safety of the staff and the emotional exhaustion of the staff. So you can take a leadership behavior like rounding, and when you do it in a particular way, like by guaranteeing that you're going to give feedback to them on actions taken to resolve the issues that were surfaced during those visits, and if you're kind of interacting with them in a way that builds psychological safety, you can actually measure that. And he has a lot of data, a lot of safety culture data, kind of showing that psychological safety and emotional exhaustion are all go in the right direction when leaders round in that way. Now, building on that theme, the second talk in our first session was from Doctors Lasater. We can go back one slide. Doctors Lasater and Abigail Lenhart and David Hurtado, who talked about a version of leader rounding, which is kind of like for managers, not like senior leaders rounding, but managers and directors doing what they called work-life check-ins. And these brief check-ins lasted 10 minutes on average. They happened about 4 times a year. And by having a leader check in with you about how you're doing with your well-being and your work-life balance, just 10 minutes 4 times a year had a significant a reduction in emotional exhaustion in those workers, but also values alignment, so that people in those work settings say the leaders here value the same things that I value, which we know is a big part of creating that sense of belonging and creating an environment of trust and safety. So 2 kind of different versions of leader interactions with staff that link really directly back to the well-being of the workforce. Now we can go to the next slide. In our second session in November, we had a fireside chat with Dr. Colin West, and he talked about a lot of things related to healthcare worker burnout, but in particular, he went over the MVPs, which is meaning and values and purpose, and things that you can do that actually help with healthcare worker meaning, values, and purpose as interventions that can be used to reduce burnout. He also talked about some randomized controlled trials that looked at kind of what we think of as affinity groups, but these were structured groups, kind of semi-structured groups of healthcare workers coming together to talk about what it's like to be a healthcare worker in that particular facility. And with those kind of quasi-structured groups, those compass groups, they measured, 9 months and again, I think 18 months later, significant reductions in emotional exhaustion. So creating that sense of community, creating that sense of belonging, helping people to reestablish connections with their colleagues was shown to be a big driver of burnout in the right direction. So now we can go to the next slide, actually. And just to give you a sense of what we're going to be doing today, we're going to shift the conversation to turnover specifically. And here, I just wanted to kind of draw your attention to an article by Dr. Kyle Rader. He's a pediatric intensivist at Duke. And he looked at disruptive behaviors, but also safety culture and burnout and work-life balance and depression in these healthcare workers. And if we go to the next slide, what you can see that Kyle did was, if you rank order 319 work settings from least emotionally exhausted, so least exhausted, to most exhausted on the left-hand side in that first quartile, you can see there's a lot of healthcare workers that are actually not very exhausted at all. That's the green, that's the good quartile. That's where there's not a lot of burnout. And on the red, far right-hand side of the distribution, those are work settings that have a lot more emotional exhaustion. And the question is, if you go to one of those red work settings versus one of those green work settings, what is the teamwork like? What is the disruptive behavior rate like? What is the kind of, intentions to hang around like in those work settings where there's a lot of exhaustion versus not very much exhaustion? If you go to the next slide, you can see that when it comes to disruptive behaviors and intentions to leave, the more exhaustion, the worse off you are. When there's a lot of emotional exhaustion, you see more bullying of other people, publicly humiliating others, turning your back before a conversation is over, hanging up a phone before a conversation is over, making comments with sexual, racist, or ethnic slurs, and even showing a physical aggression. But not only did we see that link with disruptive behaviors, you see it also with intentions to leave. So when there's more emotional exhaustion, you see more people talking about, I'd like to find a better job, I often think about leaving this job, and I have plans to leave this job in the next year. So that's just to set the stage that when you look at the well-being of the workforce and you look at these critical things like who stays and who goes, there's some interesting patterns that can be predicted by the data that we're collecting already. If we can go to the next slide. As we begin to segue into our speakers for today, some things to think about is, what is the relationship between well-being, leadership behaviors, and staff turnover? Now, we're talking about staff well-being and leadership behaviors and turnover. And the second one is, what specific strategies can healthcare leaders implement to reduce staff turnover? And if we go to the next slide, to get us started here today, I want to introduce the second speaker first, Dr. Daniel Tawfik. He's an assistant professor in pediatric critical care medicine and pediatric clinical informatics. He completed medical school at the University of Iowa, pediatric residency at the University of Utah, a pediatric critical care fellowship at Stanford, and a master's degree in health policy and research at Stanford. He's funded by the Agency for Healthcare Research and Quality, who is funding this webinar today, and the American Medical Association, with a focus on applying advanced quantitative methodology to improve our understanding of the healthcare delivery system and predicting healthcare provider and patient safety outcomes using routinely generated EHR data and metadata. So that's Daniel. We'll get to him as the second speaker, but let me now shift it to Dr. Karen Lasater. She's a Ph.D. prepared registered nurse. She is an associate professor of nursing and the Jesse M. Scott Term Chair in Nursing and Health Policy in the Center for Health Outcomes and Policy Research at the University of Pennsylvania School of Nursing. She's funded by the National Institutes of Health and the Agency for Healthcare Research and Quality, who funded the webinar today, and to evaluate the impact of hospital nursing resources on patient outcomes and nurse well-being. Let me hand it over now to Dr. Lasater. Oh, can you unmute, Karen?
Thank you. That's an important step. Thank you for the opportunity to present today on what we know from the research about what drives clinician turnover and also what strategies healthcare organizations can deploy to address turnover. Next slide, please. So the scientific evidence is robust in showing the relationship between unsafe workloads for nurses and poor working conditions, which contribute to high burnout, job dissatisfaction, and intentions to leave the employer. This figure on the screen describes my conceptualization about how these issues relate to two pressing workforce concerns related to recruitment and retention. So these concepts all have a negative feedback loop, because unsafe workloads and poor working conditions make it harder to recruit new nurses, but it also drives the burnout and job dissatisfaction of the nurses who are currently employed in an organization. And research has shown a direct relationship between these poor nurse job outcomes and actual turnover in hospitals. And high turnover of nurses further exacerbates the issue of unsafe workloads. So there's really a vicious cycle here. On a positive note, unsafe workloads and poor working conditions are modifiable. And the evidence shows that hospitals with good work environments not only attract new nurses, but are also better able to retain their nurses. So before we talk about what hospitals could do to modify their work environments and workloads, I think it's informative to hear directly from nurses about the reasons why they leave their employer. Next slide. Thank you. So these are some exemplar quotations from nurses who recently left healthcare employment. In this study, we analyzed data from over 7,000 nurses, and we asked them to describe their major reasons for leaving their employer. The most common reason was planned retirement, but the next most common reasons were because of insufficient staffing and high burnout. The nurses described how better staffing would have kept them working for another year or two. Nurses talk about how much they love their work, but that hospitals were staffing poorly to save money, and this put patients as well as nurses' own health at risk. Another nurse described the issue of low staffing being dangerous for patients and nurses, this relationship to burnout, and observed how the workloads continued to increase over time while working in their hospital. This last quotation here, I think, also suggests frustration with hospital leadership, which in this case promised better staffing, but didn't deliver on that promise. What's clear from these quotations is that there's this direct relationship between staffing insufficiency and clinician burnout. And it's reinforced a major finding published over 20 years ago, actually, in JAMA, showing that every additional patient in a nurse's workload is associated with a 23% higher odds of nurses burning out. Also in this paper, we looked at the reasons nurses left healthcare employment by various age categories of the nurse. And we found that among the younger nurses under 30 years of age, they weren't citing planned retirement as their reason for leaving. Instead, 43% of them cited burnout as the reason for leaving, and 40% cited insufficient staffing. So I think this is helpful in thinking about potentially more targeted approaches for reducing turnover when you think about who your clinical audience is. Next slide, please. So on the other side, we evaluated drivers of recruitment challenges. In this study, we asked nurses how likely they were to recommend their workplace as a good place to work to other nurses. And so among the nurses who were unlikely to recommend their workplace, we asked them to explain why not. So here are some of the themes that emerged, as well as exemplar quotes to help explain that theme. For example, one of the themes was the feeling of having unlimited patients to take care of with limited support. The nurse says, quote, "I would not recommend my hospital because of low staffing that we are facing all the time. It seems that no one is addressing the issue, and as a result, we are overworked and not to mention underpaid." The nurses also described unanswered calls for help, particularly as it related to their relationship with hospital leadership. One nurse said, quote, "Burnout is rampant throughout all disciplines. Upper management appears to have blinders on to this situation." And then finally, nurses described feeling like their workplace constantly asked them to do things that would put their license at risk. So a nurse told us, quote, "Everyone is doing the best they can, but staff to patient ratios are consistently unsafe. You're constantly forced to put your license at risk. Staff is burnt out." It's notable that the same factors that drive recruitment issues are also the same factors that drive retention issues. So therefore, focusing on achieving adequate staffing, preventing clinician burnout, and developing a hospital leadership that is responsive to the concerns of frontline nurses is essential. Next slide. Thank you. In a different study, we surveyed both nurses and physicians in 60 magnet hospitals across the country about their clinician well-being. And we also obtained turnover data from the participating hospitals. So I want to draw your eyes to the 3 highlighted rows, which show us that hospitals with higher percentages of nurses with burnout, job dissatisfaction, and intentions to leave are all predictive of higher nurse turnover, as well as higher physician turnover. So what nurses are experiencing with respect to their well-being translates into nurse turnover as well as physician turnover. Interestingly, physician job outcomes were not found to be predictive of physician turnover, but the coefficients were at least directionally consistent with our hypothesis. Next slide. In that same study, we asked both nurses and physicians to tell us what were the most important interventions their hospital could do to reduce and prevent their burnout. The most important intervention for nurses was to improve nurse staffing levels. 87% of nurses agreed that this was very important, and 45% of physicians also agreed that improving nurse staffing levels would reduce their own burnout. Other top-rated interventions included supporting clinicians to take work breaks without interruptions, increasing clinicians' control over their work schedules, reducing the time clinicians spent on documentation, and increasing the time clinicians spent in direct patient care. So each of these interventions are within the control of hospital leadership to address. It was also interesting to see that some of the least favored interventions were those that targeted the individual's resilience as opposed to system level factors. So interventions that clinicians felt were not very important included things like resiliency training and creating time and places for meditation and reflection. Next slide. So bringing us back to our conceptual model, the research suggests that the interventions to resolve workforce turnover really ought to intervene on system level factors, and namely unsafe workloads of clinicians and poor working conditions, since those are the drivers of burnout and job dissatisfaction and ultimately turnover. So in my last two slides, I'm going to focus on some actionable steps to both establish safe workloads and also improve work environments for the purposes of reducing turnover. Next slide, please. So the first recommendation is to establish safe workloads is to create more staffed positions. This could be achieved voluntarily by an organization creating more staffing positions and then hiring clinicians into those positions. But in the absence of hospitals voluntarily improving staffing, external policies such as safe nurse staffing minimums, which basically serve as minimum guardrails for staffing workloads, can be enacted at state or federal levels. California and now Oregon are examples of two US states that have passed safe nurse staffing legislation. And we've also seen a growth in such legislation internationally as well. So a common criticism of these external policies is that hiring more nurses would not be financially sustainable for hospitals. But there's actually growing evidence that suggests a really strong return on investment in nurse staffing. Of course, we know it benefits patients, but we also see that it's not so threatening to hospitals' bottom lines. And here I list two papers, one that's published in the Lancet and the other in the Lancet Global Health, which offer examples in Queensland, Australia, and Chile, showing that the cost of increasing nurse staffing more than pays for itself in terms of the avoided readmissions and shorter lengths of stay for hospitalized patients. I'll also offer two cautions. The first is that when hospitals are considering increasing nursing staff, I recommend that they be cautious of lowering the nursing skill mix. So these are two papers I offer here related to quality outcomes as well as cost outcomes of hospitals substituting registered nurse care for care delivered by licensed practical nurses or unlicensed assistive personnel. And in short, what the two studies find is that greater uses of registered nurses over LPNs is a better economic investment for hospitals and yields better quality of care for patients. My second caution relates to the growing adoption of virtual nursing programs in hospitals. There is no scientific evidence on the safety or effectiveness of virtual nursing programs. In fact, preliminary evidence suggests that the majority of nurses at the bedside who work alongside virtual nurses say that the virtual nurses don't reduce their workload, or it actually increases it because it's another care team member that requires coordinating with. And then finally, I think we need to acknowledge that adding more clinicians to the workforce is not a solution to turnover issues. Training more clinicians without addressing the reasons why clinicians burn out and turn over is like putting fuel into a leaky gas tank. So healthcare organizations really need to take a leadership role in addressing the system level issues that are driving clinicians away from employment. Next slide, please. And then strategies to improve the work environment can really begin with addressing the reasons why employees are leaving their employers and working to reestablish trust among our healthcare clinicians. Part of reestablishing trust is demonstrating that the management and leadership of a healthcare organization believe patient safety and care quality to be a top priority. In our research, we find that more than half of nurses say that the actions of management show patient safety is not a top priority and that administration does not listen to or respond to nurses' concerns. So this data suggests a real disconnect, whether based on perceptions or reality, between what leadership prioritizes and what clinicians prioritize. The Impact Wellbeing Guide, which you can learn more about on the CDC website, provides a step-by-step systems-based approach for improving clinician well-being and building trust between leaders and healthcare workers. A second thing is that healthcare organizations can also track their clinician well-being metrics at regular intervals to understand whether or not the interventions they're deploying are effective strategies. I also recommend reading this work by Dr. Margo Brooks Carthon and colleagues about addressing burnout among nurses of color, and to consider stratifying clinician well-being metrics by worker demographics in order to evaluate whether tailored systems interventions are needed. So like I mentioned before, we know that younger nurses are more likely to burn out. That could raise implications about how our organizations investing in supporting new to practice nurses. And then finally, the American Nurses Credentialing Center has both the Magnet and Pathway to Excellence programs, which have been empirically associated with better nurse and patient outcomes. And then more recently, they've introduced the Wellbeing Credential, which focuses on assessing and enhancing well-being programs in healthcare organizations. So I encourage organizations to check out these programs if they have not already. Next slide. And so here you can find many of the papers that I referenced if you link to the QR code, and I also welcome you to reach out to me by email. So I'll turn it over to Daniel. Thank you.
All right, thank you very much. So as Brian mentioned, so I'm Daniel Tawfik, and today I'm going to be talking about healthcare leadership implications for workforce engagement, turnover, and patient safety. I do have some research funding, but no other disclosures. So on the next slide, I just have a brief outline of what we'll go through today. I'll share a little bit of background on what's already known on this topic. Then we'll go through some recent findings and some implications. So on this first slide in the background, there is a body of literature kind of around healthcare leadership. And one of the things that we know from that literature is that leadership associates with well-being, with healthcare worker well-being, and so strongly that actually just a single point increase in leadership scores, and these are scores that are anywhere from a 36 to 48 point range, just a single point increase associates with anywhere from a 2 to 7% decrease in the likelihood of burnout, an 8 to 11% increase in the likelihood of satisfaction with the organization. Next slide. And then in addition to leadership associating with well-being, we also know that well-being associates with intentions to leave. And so some studies done with surveys as far back as 2014 found that healthcare workers, these were physicians specifically, who were experiencing symptoms of burnout had nearly twice the odds of reporting intentions to leave their organization. You can see from the figure there that it was largely independent of the physician's age. And then some follow-up surveys that were done mostly during the height of the COVID-19 pandemic response, actually, found even stronger relationships where burnout had over 2.5 times the odds of individuals reporting intentions to leave if they were having symptoms of burnout. And then in addition, work overload associated even more strongly with burnout. So individuals, these are not just physicians, but physicians, nurses, and a whole other host of healthcare workers reported over 6 times the odds of burnout if they were reporting feeling work overload. And work overload itself directly associated with intentions to leave, with over twice the odds of intentions to leave. Now, this intentions to leave survey item is a convenient one to ask, and it's one that is used rather frequently because it's something that you can ask people on a survey. But really, the real question is if individuals are actually leaving the workforce and are they actually leaving the organization. So on the next slide, I show the results of a study that actually tried to answer just that question. And what they did is they surveyed all the healthcare workers in their organization on their intentions to leave, and then followed up 2 years later to determine among those who actually did truly leave the organization. And what they found was of those who reported intentions to leave, around a third of them actually did leave the organization within that 2-year period, which was much higher than kind of that baseline rate of just about 1% of those who didn't report intentions to leave leaving the organization within the next two years. So next slide. So that's the background on which I'm going to talk about some of our recent findings as well. So on the next slide, I'm sharing just kind of an overview. These are the 2 papers that most of these findings that I'm going to talk about are reported in. And what we did for this study is we surveyed just under 15,000 healthcare workers, of all disciplines, all across the state of Michigan. And we asked them 5 questions about their local leadership behavior, which is the local leadership scale, which is part of the SCORE survey. And in relation to those 5 local leadership items, we evaluated well-being, engagement, and intentions to leave measures. So on the next slide, I show a couple results that should not be too surprising to you based on the first few slides I showed. Leadership associates with well-being. So people in work units with low local leadership scores, those are the ones shown over on the left bar here. This is the lowest quartile of local leadership scores, had by far the highest emotional exhaustion rates, and that decreased quite linearly as the local leadership scores improved. And similarly, well-being associated with intentions to leave. So individuals with higher and higher emotional exhaustion scores, we see in the dark blue bars on the second graph that they were more and more likely to report intentions to leave, to the degree that actually those on the far extreme end of emotional exhaustion scores were actually more likely to report intentions to leave than not. On the next slide, we actually show direct relationships between those same local leadership scores, but in this case now workforce engagement measures. So again, looking at the quartiles of local leadership scores, so those units with the worst local leadership scores had the highest reported of their workforce having activities restricted due to illness, but also the highest reported missing work for any reason. And on the next slide, we'll show the relationship with high workload and with intentions to leave. So again, the lowest local leadership quartiles had the highest perceived workload. And in particular, for those who were in the lowest local leadership quartile, they had higher intentions to leave. And this is further illustrated on the next slide, where we did some logistic regressions. And the one to really highlight here is the intentions to leave item over on the right. So this is a logistic regression. We're adjusting for the work unit, the job type, because these are all disciplines of healthcare workers that are involved, adjusted for years of experience and the patient care type. After all of those adjustments, each 10-point increase in local leadership score, this is on a 100-point scale, so that's about 1/10 of the way across the scale. Each 10-point increase associated with an odds ratio of 0.80 for intentions to leave, so a 20% reduction in intentions to leave for each 10-point change in the local leadership score. So if you go to the next slide, you may remember I said that we asked 5 individual questions that made up this local leadership scale. And this is where I wanted to really focus to talk about some action steps. The the 5 items on the local leadership scale can really sort of be categorized into 3 different groups. One is about the availability of leadership, listed as available on this chart. Setting clear expectations, which is the one all the way to the right, the setting clear expectations, and then 3 items related to feedback. And I've highlighted those feedback items because although all 5 items correlated, rather strongly with intentions to leave, the 3 that really showed the strongest correlations were all related to feedback. So reporting useful feedback by local leadership was the strongest correlation, followed very closely behind positive feedback from the leader, and then followed closely behind by frequent feedback from the leader. And so if I were to leave you with 3 action steps related to this, it would be feedback, feedback, and feedback, both useful, positive, and frequent. And one thing that we did in a separate study is we actually did semi-structured interviews in a qualitative study with academic physicians. These are outpatient and inpatient, adult and pediatric academic physicians. And part of what we asked them was, what makes feedback helpful to you, and what about feedback actually helps support your well-being? And some of the themes that really came up from that study, a lot of them were around the usefulness of feedback, consistent with what we found here. And really what they reported to us that made feedback useful, one is if the content actually is content that matters to them. So if the content of the feedback actually matches up with their career development goals or with items that actually they care about, they found that to be much more useful than if they were being given feedback on metrics that they really don't care that much about. The other thing that people found, which was related to positive feedback, is that reinforcing feedback is helpful. And so that's stating what's going well, what they should be doing well, and what they should continue to do more of. But another aspect of positive feedback was not necessarily just that reinforcing feedback, but if the feedback was given from a posture of coaching or guiding. And that was actually also perceived to be positive feedback, even if the actual content of it was something that was negative. And then the frequency of feedback, the other thing that we found from these interviews was that when people are receiving feedback, they may not always recognize that they're receiving feedback, particularly if it's outside of kind of a formal feedback structure. And so clearly defining when feedback is being given and calling that out can be particularly beneficial. So on the next slide, I just wanted to share a couple implications actually from a separate qualitative study that we did. And I won't read through all of these quotes just for the sake of time, but this was a study where actually we were interviewing physicians about technology, frustration with technology, and its relation to burnout. But one of the themes that kept bubbling up was this concept of turnover, churn, and destabilizing change. And so what we found was that physicians reported that physician turnover affects other physicians. And a large part of that was that when a physician leaves an organization, that gap in care needs to be filled, and it gets filled by the physicians who are remaining. So this quote on the right says, "One of our colleagues recently left, and he had a very busy practice. So we've had a hard time hiring a new doctor, and now we end up seeing his patients." On the next slide, I have a couple quotes about how nurse and other staff turnover affect everyone. And so these were outpatient physicians, so they were talking mostly about clinic nurses and medical assistants. And what we found was that destabilizing change really can have ripple effects kind of throughout the whole clinic. The final slide with quotes is probably one of the more poignant quotes that we had from this study, and that's because turnover affects patients. And so this is a quote from a physician shortly after they were talking about how a colleague left their clinic, and they were having to see new patients all the time and having to cover for colleagues who had left. And this physician said, "It's very, very hard when the first time I'm meeting a patient, I sit down in front of them, say, 'Hi, nice to meet you,' and they say, 'Hi, you're not going to leave, are you?' Because they've had literally the last 3 of their providers leave within the last 6 months." And so the final thing I wanted to leave you with is just a framework that we've been using. This was developed primarily as a framework around prescribing errors or medication errors, but it could be adapted for other patient safety concepts as well. And what I wanted to highlight here is that we're really looking at individual actions, but in healthcare, individuals are almost all operating as part of a team, and the teams are all operating within the healthcare system. And the risk factors for patient safety events and the risk factors for not catching errors before they reach patients all really can boil down to mostly one of two things. One has to do with workload and cognitive burden, which can be exacerbated by turnover. And another at the team level has to do with communication, which also can be exacerbated by turnover, decreased team size, or decreased familiarity with team members as they change out. And so this is just to highlight how important it is to get this right. But I wanted to make sure that we are leaving some time for questions as well. So I'll turn it back over to Brian.
All right. Thank you, Daniel, and thank you, Karen. I'd love to open it up for Q&A. To the extent you have questions or comments, please go to the chat and put that into the chat. We've already got several in here, and I did want to reflect very briefly, just to kind of two different researchers having some findings that overlap in some interesting ways. One of the things that really popped out is, Karen, in your presentation, you talked about how there's a need to reestablish trust if you want to reduce the turnover in nursing. That trust has been harmed, and in some interesting ways, that was a theme in a lot of what Daniel was talking about too, when he's going over local leadership and giving feedback and the things that you can do. I wonder if either of you have any comments about that, and I do want to loop back because there was a question: can we give a more specific definition for local leadership? But do either of you have any reflections on that trust factor as driving so much of what's happening right now?
I'm happy to start. Thanks for the question. So one of the things that we found in our research is that even with good intentions, hospital leadership trying to do things to solve nurse burnout, if it's not approached in the right way, or if it's not in alignment with what clinicians are telling their leadership they want, that actually starts to erode trust even more. So for example, when nurses are saying we need to improve our staffing levels, and leadership responds by offering time and space for meditation and reflection, nurses are like, that's not what we're asking for, and that's not actually going to solve our problems. Another example of this is that there's a lot of evidence behind nurse workloads and patient safety and nurse outcomes. We have 3 decades of research. It's very well evidence-based. And yet many hospitals are investing a lot in virtual nursing programs to try and improve nurses' workloads and reduce turnover, but there's no evidence base behind those. So clinicians are sitting at the bedside saying, why is my hospital not investing something that has very rich evidence base and turning instead to something that lacks an evidence base? And so those kinds of decisions, even though they might be made with the best intentions by an organization's leadership, really call into question for many frontline nurses, like, are they acting with patients' best interests and evidence at the center of their decision making?
Yeah, and I would just piggyback on that and say kind of one overarching theme that we've found in our well-being research is values alignment. And so if the healthcare workers don't feel that administration values the same principles that they value, then it's very difficult for them to have trust in leadership and have trust in those leadership decisions. And in particular, kind of through the lens of feedback, the purpose of the feedback can actually really color how somebody perceives that feedback and how they receive it. And so if they perceive that the feedback is trying to drive a value that they don't care about quite as much, personally or professionally, that feedback is going to be much less valuable to them and is not going to support their well-being, as well as one that really kind of aligns with their career goals and their patient care goals.
The questions are rolling in here, so I want to kind of push us towards that. There was one question about local leadership definition. I just want to give a quick point to that. When you're talking about local leadership, you're not talking about facility leadership. So the distinction is between people who are running a facility or senior leaders versus a nurse manager or a medical director or a unit kind of manager. So it's specific to that local work setting. Specific leadership. Just to clarify, we got it. I'm trying to figure out where to start here. Here's one from Holly. How are facilities partnering with schools of nursing to increase graduation numbers and address nursing shortages? Assuming that's for you, Dr. Lasater.
Hi, Holly. Thanks for the question. So there's actually no evidence that we're in a nursing shortage, and I think that surprises a lot of people because we've seen headlines in the media saying that like we're in a nursing crisis. I've described it as we're really in a nursing care crisis, not a nursing shortage. So we have sufficient numbers of nurses in this country. It's just that we don't have as many nurses willing to work as we need. And again, as we've talked about in this webinar today, the reasons they're not willing to work is they're burnt out. Their organizations provide insufficient staffing, and they're basically asked to come into a workplace where they're put in positions that they're transgressing their professional and moral ethics to try and provide good, safe patient care. And so nurses are opting out of employment and healthcare settings. With respect to nursing numbers, we've actually had even through the pandemic, record-breaking numbers of nurse graduates year over year, and we continue to have that. So the issue is really not with the interest of young people in the profession of nursing. That's never been stronger. And it's not related to how many new nurses are entering practice year over year, because that continues to grow. I think the real question at the heart of turnover is really about why are nurses who have been trained and invested in and have spent 4 years or more getting this education and license dropping out of a workforce within 1 or 2 years even of clinical practice? And what are we doing in our healthcare organizations to address that leaky bucket?
But before we go back to some questions about leadership specifically, Karen, you gave a nugget that I was not aware of, that if you invest in RNs as opposed to LPNs, that pays for itself. I wonder how well known that is in people who are in charge of the HR duties around this. Is that an esoteric fact, or is that drawn upon and there are models where people are making sure that they're staffing in a long-term way that affects patient safety? I'm just curious that was a great nugget. I just want a little follow-up on it.
Yeah, so we did a follow-up of really one of the initial studies, which I cited from Jack Needleman, I think it was in the early 2000s, where he showed this kind of relationship between LPN hospitals that had higher proportions of LPNs relative to hospitals that had higher proportions of RNs in their nursing workforce. And the reason that we came back to that study and looked at it again is because a lot of hospitals after the pandemic have talked about and have implemented something that's called team nursing care, which instead of primary nursing, which is where a registered nurse kind of oversees the care of some number of patients, team nursing has fewer registered nurses and more of the direct care is given by licensed practical nurses. And so that's really our motivation for revisiting this question, but we find consistently again and again that when nursing skill mix is lower, meaning that there's fewer registered nurses providing patient care in a hospital, that patient outcomes are worse, patients are more likely to die, quality of care is more likely to be lower. But also importantly, we looked at the kind of financial implications, because from an HR perspective, it's more cost effective to hire a LPN or an unlicensed assistive personnel, which frequently has a lower hourly wage than a registered nurse. So on the kind of payroll, it looks better. But when you look at the long-term financial consequence of that HR decision, you see that the poor outcomes of patients, principally more readmissions and longer lengths of stay, actually end up costing the hospital in the long term.
Thank you for clarifying that. That was you put a wrinkle in my brain. I did not know that one. Daniel, I think this one is for you. This is from Wendy. Do you think that the lack of quality leadership is related to the lack of training in leadership, which is not uncommon in fields in which there are high skill demand trainings required?
Yeah, that's a great question. And I think the short answer is yes. And so, yeah, particularly in healthcare, the criteria for being promoted to leadership roles really is misaligned with the criteria for being a good leader. And unless there is a concerted, intentional effort to training people in leadership skills, just somebody meeting the qualifications to be a local leader, the criteria that we typically use just really don't match up with those leadership skills. They're usually more based on kind of research successes or clinical acumen, and none of those things necessarily mean that there's good leadership. There are leadership training options out there, but like you alluded to, they are they're intensive. They're not easy to go through, and so it really, I think, takes a concerted effort from administration to prioritize leadership development among people who are being promoted to leadership roles, or changing the criteria for promotion to leadership roles to people who already have those skills or have demonstrated those skills. But yes, I think it's definitely a mismatch that then kind of results in this scenario where you have people in leadership roles who are not really qualified to take on some of those responsibilities.
Yeah, I think that there's also been just an explosion in the use of executive coaches in healthcare for leaders to go. And it's a lot of them were former therapists that decided that they could have a different clientele by moving their practice into the coaching space. But there's some really interesting data really showing that that coaching is not just good for the coachee, but it also reduces their burnout, and people who are trained as coaches to be peer coaches, it can actually affect the burnout of their peers as well in a good way. So yeah, we need somebody to kind of show us the way on how to be psychologically safe, and we throw that word around a lot, but it results from things that we say and things that we do. It's not just in the ether magically bumping around. Here's a question from Karen. How is the evidence in terms of workplace violence and burnout turnover? How does leadership play a role in that relationship? Leadership play a role in the relationship between workplace violence and turnover. I don't know if either of you want to I can make a comment, or either of you can make a comment about that. I'll jump in and say that what's interesting in the research that I'm aware of, and a few studies that we have done on it, is that when we first started looking at workplace, in particular disruptive behavior, so I can't speak to workplace violence, and that's something that's really taken off since the pandemic. But just in terms of disruptive behaviors, we used to ask people what was the disruptive behavior, and then we'd ask them whether or not it was managed well. And the correlation between the frequency of disruptive behaviors and whether or not they were managed well was in the 9s. It was like 0.92. So we got to the point where we didn't need to ask whether or not it was managed, because if it was happening frequently, it was not getting managed. And so you've heard the sayings, what you permit is what you promote. What the standard you walk by is the standard that you permit. So I think that when it comes to these really tricky things, like people are exhausted and they act out and they do things that are uncharacteristic, it's not acceptable, but you can look in the totality of kind of like what are the breeding grounds for these behaviors. Leaders can't just ignore them. And I think that when we ignore them, we create environments where I don't feel psychologically safe, which is an underpinning of both of you talked about today from both of your kind of areas of research. Is if I don't feel safe, it's kind of game over for me being present and me being, an advocate for patient safety for my patients. If I don't feel safe, how am I supposed to make patients safe? So I think that the buck stops with leaders. Unfortunately, it's hard to be a leader in healthcare right now. It's like it's just one more thing that our leaders have to think about. I can go through and answer some of these questions, but I'm wondering if either of you have a question you'd like to answer as we go. You can read through them, and I can kind of keep going.
I'm happy to answer a question. I saw someone asked, are there studies that support team nursing? So my understanding of what team nursing is, and I want to make sure that we're operating from the same definition, is team nursing is where a registered nurse cares for a sort of panel of patients and kind of oversees and helps direct care delivered through LPNs and unlicensed assistive personnel, as opposed to where the registered nurse is the primary nurse delivering patient care. So that would be sort of my definition of team nursing. It's essentially what we see with lower skill mix. So I here am sort of equating the two, that when you have a lower nursing skill mix, you're operating in a team nursing model as opposed to a primary nursing model. And what the evidence has shown, both here in the US as well as international studies, is that when there is a lower proportion of care delivered to patients via registered nurses and more of that care delivered by licensed practical nurses or unlicensed assistive personnel, that patient outcomes are worse. And that research has been consistently replicated in different hospitals in different states and different countries. So I would say, yes, there is evidence about team nursing, and it falls largely in the camp of it's not as good for patient outcomes as primary nursing care, where the registered nurse has primary responsibility. The reasons for that, I think, are fairly self-explanatory, primarily that the registered nurse is kind of overseeing all of the care as opposed to being sort of fragmented in their care, only thinking about med administration or only thinking about one thing. So patient care, we really want to be considered in whole as opposed to fragmented among a lot of care providers. The research also shows that nurses who are engaged in team nursing models have lower job dissatisfaction. And we don't know exactly the reason behind the lower job dissatisfaction, but I would again hypothesize is that their care delivery has become fragmented into tasks as opposed to caring for a patient as a whole.
Kind of the diluted bedside relationship and the sequelae of that. Thank you, Karen. There's more questions are piling up here. Here's one. This is from Jennifer. Are you looking at all at burnout in non-clinical staff, unit clerks, environmental services staff, et cetera? I wonder if either of you want to comment on that.
Yeah, I can comment on that one. And so, yeah, actually the survey study that I showed where we're looking at local leadership in relation to workforce engagement and well-being, that was done amongst all healthcare workers. And so that included unit clerks, billing, custodial staff. It included kind of anyone who was working anywhere within the healthcare environment. And the interesting thing we did is if we split out clinical staff, what we call them direct patient care versus indirect patient care. If we split out those who are participating in direct patient care, the physicians, nurses, respiratory therapists, et cetera, to those who are doing indirect patient care, the relationships looked nearly identical between leadership and burnout, between burnout and intentions to leave. And so I thought it was actually quite interesting because it's the type of thing that, on the face of it, I thought, well, these are going to be different relationships and these are totally different roles. But really what it came down to, I think, is that these are all kind of human connections, human responses, and a lot of it really kind of transcends what the specific role or discipline is. And so, yeah, we found very similar relationships, even when split into like clinical or non-clinical.
Yeah, thank you, Danielle. As you reflect on that, one of the things that strikes me is if you look at accountants that work in healthcare, people who work in IT in healthcare, people who work in marketing or in finance in healthcare, relative to their counterparts outside of healthcare, they all have higher burnout in healthcare, right? Their counterparts don't have the same burnout outside of healthcare, which just speaks to kind of like there's, it's an intense work setting, not just for the clinicians. So that's a thanks for clarifying. What I'm looking at here, Karen, is a comment from Angela. I didn't know if you wanted to speak to this. Is there evidence in modifying the work processes and team atmosphere so that the current staff can work more effectively without necessarily adding additional staff? And there was another comment about teamwork and team training. I just wonder if you have any comments about because a lot of people don't have the budget. So what are the if you have this is the staff you have. How do you optimize what you got?
Yeah, so there's a lot of research on things like operational failures. This is nurses saying that their work was interrupted or delayed because of avoidable things like missing medications. That they're basically the nurses are spending their time doing a scavenger hunt around the hospital to try and get the things that they need to deliver patient care. So these are called operational failures. And again, it's really in the purview of hospital administration and leadership to address those operational failures. There's also things that nurses feel like they're not spending enough time in direct patient care, which is part of what more staffing would enable them to do, but in part because they're spending time trying to get in contact with the physician or doing documentation, which might be streamlined more efficiently. So there's certainly things that nurses are doing in their work processes that are eating up valuable time that they could be spending in direct patient care. But again, I go back to the thing, if you ask nurses what they need to reduce their burnout, the number one thing they say is they need more staff. And I always say nurses are problem solvers. They are natural problem solvers. They are really in the trenches. They are there giving patient care, and they understand what they need. And they're developing workarounds. They're developing work processes to address these problems. But the thing that they really need from their organizations is enough people on the ground to deliver patient care.
Yeah, thank you, Karen. I think it's interesting to just reflect on, years and years of team steps training, things that you can do it should never be a substitute for adequate staffing. It's often used that way, unfortunately. But it is interesting to note that when there is effective teamwork, even, if you take two groups with the same staffing levels, effective teamwork in group A versus ineffective teamwork in group B, they have wildly different perceptions of staffing and wildly different, burnout and turnover rates. So teamwork does make a difference, but it shouldn't be, we shouldn't be looking at kind of a surrogate for staffing. Teamwork should just be a given, right? Having good teamwork norms and skills and training and tools and resources. So please, everyone, let us know in the chat, what would you like to learn more about to address staff turnover in your organization effectively? We will gather that information. We can share that also with our speakers today. If we can go to the next slide, I would love to go ahead and start to bring this conversation to a close and introduce you to some of our upcoming events of interest. I want to give a heartfelt thank you to both Dr. Lasater and Dr. Tawfik for covering. Those mini sessions are hard to do, and you both just nailed it. So thank you so much for that. Coming up in January is our webinar for engineering safety into practice through implementation of the EHR Safer Guides. You can register for that on the AHRQ website there. Also, if in the next slide, we have an upcoming series for safety culture in healthcare, and that will be another fun one with lots of good nuggets and lots of good presenters. So please, you can register for that also on the website. Check that out. And if you can't make it live, take the recording and listen to it. That's what a lot of people do as well. But we thank you for your attention today. We thank you for coming and joining us. And with that, we'll go ahead and pull the webinar to a close today.